So today, I would like to talk briefly on the technical tips of the Nutcracker Doppler diagnosis. The first publication I wrote about this Doppler ultrasound diagnosis was 1996 in Radiology, and in that paper, my conclusion was that we are able to make a diagnosis of Nutcracker with Doppler ultrasound. But after I published this paper, so I heard a lot of things from the people who read this paper and tried to do Doppler ultrasound in Nutcracker diagnosis, and many of them said it's too difficult to do. So I thought about why it was so difficult to them. This is a patient, 30-year-old woman with proteinuria, and probably this grayscale and this color Doppler ultrasound the best image ever I had in Nutcracker patient. This grayscale clearly shows the compression of the left renal vein between aorta and superior ventricular artery, and the color Doppler clearly shows the compression here, and we see bright colored elevating flow here, jetting flow here. And with spectral Doppler ultrasound, the flow here is this continuous flow with peak flow velocity around 20 centimeters per second. And in this area, the jetting flow, it shows the peak flow velocity around 150 centimeters per second. This is, if the images in all patients are like this, it may not be difficult, but in clinical practice, not every patient is this clear, the images. And in the last talk, I mentioned that at least there are 3 subtypes of Nutcracker. Classical type, the compression of the left renal vein in a narrow space between aorta and superior ventricular artery. This is a type 1 classical Nutcracker. And the second type is the left renal vein is not compressed between aorta and superior ventricular artery, but is compressed by the origin of the right renal artery from behind after passing this aortoventricular space. And this is type 2, and compression occurs by the origin of the right renal artery. And the third type, the left renal vein, is like stretched over the abdominal aorta. The space is not, aortoventricular space not narrow, and there's no compression by the right renal artery. The left renal vein is compressed here by stretching over the abdominal aorta. So these are main 3 subtypes of the Nutcracker. Let's see each example. This is an example of type 1 Nutcracker. So we should see a man with proteinuria and fluctuating glomerular filtration rate. Aorta superior ventricular artery space is narrow and compressed here. The left renal vein is dilated. And with this color Doppler ultrasound, we can see the absence of flow signal in this dilated left renal vein. It means that very sluggish flow here. And we do not clearly see the jetting, but with spectral Doppler ultrasound, we can see the Doppler spectral signal with high peak velocity it is around 180 centimeters per second. So it is a severe type 1 nutcracker phenomenon. And one thing important is this force in this dilated longitudinal vein is very sluggish. This is example type 2 nutcracker phenomenon is compressed by the origin of the right venial artery. Here is a dilated longitudinal vein, aorta, supramedullary artery, and this is the origin of the right venial artery. The colored approach side is smooth flow here and here, and the very bright flow signals from here. The origin of the right venial artery is right here. So we clearly see that compression occurs here by the origin of the right venial artery. This is not compressed severely here, and the left venial vein is not stretched over the abdominal aorta. So this is clearly shows that this is type 2 nutcracker, and peak flow velocity is 113. So normal value is 40 to 50. So there's a nutcracker phenomenon and a type 2, and probably, but this patient did not have any symptoms. So this is a case of type 2 nutcracker phenomenon. This patient is not a nutcracker syndrome patient, but this patient is asymptomatic patient with type 2 nutcracker phenomenon. And this is example of type 3 nutcracker phenomenon. This patient, old female patient, with growth hematuria and heavy bladder symptoms. And with respiration, and we can see the left venial vein here, and supramedullary arteries here is not compressed between the space, aortomedullary space, but the left venial vein is stretched over the abdominal aorta. Right venial artery is right here, and so not compressed by the right venial artery. So this is a type 3 nutcracker, and stretched over here, and we can see the bright colored fast flow here. Peak flow velocity was 148. So this is type 3 nutcracker syndrome patient, and probably this hematuria and blood symptom was caused by this nutcracker phenomenon. So this is a patient with nutcracker syndrome. I thought over why the patient feel difficulty in nutcracker Doppler diagnosis. Probably I think those are 4 reasons why the people who are trying to do Doppler diagnosis of nutcracker had a difficulty. First is the Doppler angle. If we do not have a proper Doppler angle, the procedure will be difficult. And the second issue is sample volume. If we use narrow sample volume, it will be difficult. And the third issue is patient breathing. If we ask the patient to hold breath repeatedly, patient feel exhausted, and we may have a difficulty in getting patients' cooperation. And so it may be the third issue why we feel difficulty. So the solution is we just do ultrasound, double ultrasound exam, or patient have a comfortable, continuous breathing. And the last issue we may have difficulties the compression by the transducer. I will show you those 4 examples of those 4 issues. So this is a schema we are doing Doppler, and the neutral position of the patient and neutral position of the transducer, and both kidneys are here, lateral vein. So in this hilar portion lateral vein, Doppler angle is quite good, so we do not have any difficulty to getting the Doppler spectrum here, like this one. And then we are getting spectrum here, and we see clear Doppler spectrum from this highlight portion of the left renal vein, the low peak flow velocity. This is very easy, but we have a problem here. In this neutral position of the patient and neutral position of transducer, usually the angle between the ultrasound beam and the left renal vein is rectangular. So it is theoretically impossible to get clear, good Doppler spectra. So this is like this. We can see pulsating arterial signal and the noisy venous signal here, but we do not get any clear venous Doppler flow signal because of this angle. The solution is we rotate the transducer a little bit counterclockwise. Then the region of interest is located in this corner of the image. Then the Doppler angle will be much better than this the rectangular angle. But still, we do not get clear Doppler spectra because the sample volume is very narrow and the pulsating vessels is here. So it's difficult to get spectrum from this narrow sample volume. The solution is we increase the widening the sample volume, and then with this precision we can get quite better venous Doppler spectra here. So the images show that how we can get better Doppler angle. Just rotate the transducer slightly counterclockwise and increase the sample volume. That is the solution. So with that, the region of interest in this corner of the image with a better Doppler angle and the wide Doppler spectrum, we can get clear Doppler spectrum. So we can overcome the first issue, Doppler angle, and second issue, sample volume, with this technique. Now the third issue is the patient's respiration. So with this quiet, comfortable respiration of the patient, we can do Doppler exam of the left renal vein like this. With patient respiration, with color Doppler ultrasound, we clearly see the left renal venous flow here, and the fast flow between the aorta and the supplementary artery, and the bright color, the jetting flow here. So we do not need to ask the patient to hold the breath, because if we do this repeatedly, patient feel exhausted. This is a 78-year-old patient, asymptomatic patient, and the grayscale shows the quite wide aortometric space, and the left renal vein runs here, and the flow signals of the left renal vein, we see red colored flow here, and we see a little bit bright colored here. But if we consider this color bar between plus minus 18 centimeters per second, and with proper this velocity is not very high around here. And if we measure the flow velocity, and like this spectrum, according to the respiration, and the peak velocity is 74. So this is a not very high velocity and much less than the criteria of 100 centimeters per second. So this patient does not have a nutcracker. Probably this is a normal certain compression in this area. So this is a case of the normal longitudinal venous Doppler, color Doppler findings. And this is a 36-year-old woman had a foamy urine and glomerular filtration rate fluctuation and compression here, compression between aorta and the supplementary artery. And we see the color flow signals here. And if we ask the patient hold the breath in through inspiration, we can clearly get spectrum like this continuous spectrum. And peak flow velocity, it was 133. And with the patient who her breath in full expiration, the peak velocity was much higher than this, 185. So now we learned that peak velocity in expiration is much higher than peak velocity in inspiration. It means that compression in expiration is stronger than in compression of the left renal vein in inspiration. With the patient's continuous respiration, so like we can get Doppler spectra like this cycle. This is the expiratory cycle. This is inspiration, expiration, inspiration, expiration, inspiration. And the peak flow velocity was in expiration, and it was 165. So we should know that the degree of compression is different in inspiration and expiration status. This is a 74-year-old woman with left lower quadrant pain, and the grayscale, the aorta, supplementary artery, left renal vein here, and it looks like this is a type 3 nutcracker stretching out the abdominal aorta, and a little sluggish flow in this left renal vein, and fast flow, jetting flow here, and this is a Doppler spectrum along the respiratory cycle, and the peak flow velocity is in this expiratory cycle. It is 163. So we should know that there's normal the respiratory changes of the Doppler spectrum, and peak flow velocity is higher in expiratory cycle. So I talked about the patient respiration. The last thing you may feel difficulty is the compression by the transducer. This is a 70-year-old woman, had a epigastric pain, and this is a color ultrasound with a very light touch of the transducer without any pressure on this abdominal wall and the aorta, supplementary artery here, and this is the left renal vein, and we see the fast flow here, and probably this is the origin of the right renal artery. So probably this patient has a type 2 nutcracker, and the peak flow velocity 169 in these images without significant transducer compression. If we apply a little bit compression into abdominal wall by the transducer, then the degree of compression becomes more stronger, and the peak flow velocity increases like this, 213. And if we apply stronger compression here, then peak flow velocity increases more than 300. So it's a big difference without compression and with strong compression. So we should keep in mind that if we apply transverse compression to see the images better, then probably the degree of compression become stronger artificially. So recommendation is do not apply the compression and touch the abdominal wall lightly without any compression. That is the solution for the last issue, transverse compression. So we discussed about the Doppler angle. We can rotate, and the sample volume. We need to increase the sample volume, and we ask the patient to keep comfortable continuous respiration, and we do not apply excessive transverse compression in the anterior abdominal wall. That is the solution for the difficulty in Doppler ultrasound examination of the nutcracker. I will talk a little bit more on the other things we can get from the color Doppler ultrasound images. And this is the woman with frequency cystitis and had a nutcracker, probably type 1, and also probably having the type 2, and probably type 1 plus type 2, the compression here, and fast flow signals here. And one thing is we see this part of the lateral vein where shows the homogeneous red color flow signals. It means that continuous the flow here in this proximal lateral vein. And in this patient, the young man with gross hematuria, and probably type 1 compound here, and maybe type 2 compound here, lateral vein is dilating, and we do not see prominent flow signals here. It means a very sluggish flow here. It means that the compression here is severe, and it is dilated, and probably is a pressure in the intravenous veins of the left kidney is probably very high, and probably that is related to this patient symptom gross hematuria. So with color Doppler ultrasound, like this left-sided image and this right-sided image is probably this has a very different significance. So this observation in this color Doppler ultrasound about the signals in this dilated proximal lateral vein is one very important thing we need to observe in color Doppler ultrasound. And another thing is the patient posture. I will talk a little bit more the postural variation later, but I'll show you this example. 62-year-old woman, left flank pain. This is a color Doppler, grayscale color Doppler supine, aorta supplementary artery, and a little bit flow signal here, and low flow signal here. Probably that as there are collateral vessels, and we do not see prominent flow along this lateral vein. And if we, as the patient, a little bit rotate to the left side, so about 10 degrees, subtle rotation of the body, then it's quite different. And now we see intermittent flow signals here, and also the fast flow here. And but it's the flow in this subtle rotation is very different from flow of this flat supine posture. If we ask the patient 30-degree rotation, and this compression is very relieved, supplementary artery is here because of rotation to the left side, and the compression is very relieved, and we see continuous smooth flow here. So then, in this posture, probably the pressure, the lateral venous pressure will be much lower than the venous pressure in the supine position. This is the left 45-degree rotation and smooth flow, and 90-degree left side rotation, also smooth flow. It means that if the patient is rotated just a little bit, the flow of the left renal vein may be very different. So it's a very important thing we think about the patient management, asking patient the change the sleeping posture. This is very important, and we can observe this difference simply doing the color ultrasound with patients settle, patient gradual rotation to the left side. Another thing is in this patient, proteinuria, because of bowel gas, probably it's impossible to see the aorta, impossible to the supplementary artery. But if we turn on the color ultrasound, a lot of noises here, but we can see the right color signal here. Probably aorta is around here, supplementary arteries around here. Left renal vein is through here, and we see the bright colored flow signal here, and we can measure the peak flow velocity. So even if we do not see left renal vein, clearly do not give up and we turn on colored ultrasound, we may get quite nice Doppler spectra from the left renal vein with the quite fast flow, and we can make a diagnosis of nutcracker syndrome, peak flow velocity 175 centimeters per second. Young man is the fluctuating glomerular filtration rate, and because when I'm doing ultrasound, in this patient, I first need to examine the right kidney with the left down, left lateral, the decubitus posture, and then examine the left kidney with the right down posture, and then ask the patient and keep have a supine posture and examine the other parts of the abdomen, and lastly, I examine the left renal vein. So in this image, I tried to examine the left renal vein, but it's not easy to get Doppler signal from the left renal vein, probably pulsating vessels here, maybe aortas around here, and probably that will be a supplementary artery. And if we wait a little bit, 1 or 2 minutes, then we see better the aorta, supplementary artery, and the left renal vein is a little bit more dilated, and we see flow signals here, and wait a little bit more, a few minutes more, then the left renal vein is more dilated, and we see the flow signals here, and we see quite fast flow here, and from here we get Doppler spectra, and the peak flow velocity was 123. So we can make a diagnosis that this patient is a nutcracker phenomenon, and this young patient's symptom of fluctuating glomerular filtration rate might be related to this nutcracker phenomenon, and ask the patient to change sleeping posture and then repeatedly to check the glomerular filtration rate, and then in this patient the glomerular filtration rate recovered. So this case gives us the information that we do not need to hurry up too much. We need to wait a little bit, and then probably we can see a left renal vein better probably this is a cumulative effect of lateral compression in supine position. So this is the last slide, and I will finish my talk here. And so we had these three seminars today, Doppler techniques, and next seminars we will discuss the CT diagnosis of nutcracker syndrome, and the date will be the last Tuesday of the February 24th, same time, 11 p.m. And I will see you in February. Thank you for your attention.